that being said, if we look at it merely from a herbal or a healing perspective, I tend to think that the microbiome is what keeps Candida in check, or the fungal overgrowth in general in check. And so I like to run the SIBO part with a little bit like a maintenance dose of the SIFO. That may include, a little bit of caprylic acid or SF722, which I love. Does this make sense to you?
Yeah, I've actually never done that. So that's actually something to consider, because it just kind of keeps it at bay a little bit. Because I would do similar things if I'm treating SIBO with elemental, just because like elemental diets, amino acid diets, can actually increase the risk for SIFO to occur,
Exactly.
especially if it's like kind of low grade at that point. So I do use it with that. So I never thought about that.
Welcome to the biohackingmyillness.com podcast. Biohacking your way to optimal health. The content of this show is for informational purposes only and is not intended to diagnose, treat, or cure any illness or medical condition. Nothing in today's discussion is meant to serve as medical advice or as information to facilitate self-treatment. As always, please discuss any potential health-related decisions with your own personal doctor. And now, your host and biohacking coach, Dr. Arthur Mariano.
Hi there, guys. Welcome to another episode of the Biohacking My Illness podcast. And, I've been telling you guys that, I'm really focused on gut health for now. And I was going to bring a lot of gut health people. And you were like, yeah, but this is not really happening. I mean, you brought, Russell Jones to talk about B12. You brought Boyd Haley to talk about OSR and metabolism, then Elliot, then Stephen Fox to talk about everything and beyond. And not much is happening regarding gut health. And so this is the first of many episodes on gut health. I brought Dr. Misty Story. Misty's great. We talked about SIBO and SIFO, small intestinal bacterial overgrowth, and small fungal bacterial overgrowth, and also LIBO and EMO to some extent. I love the discussion because this is a topic that I really like. I think that in the future, if I do end up getting my FMD license, I will probably specialize in gut health, and SIBO will be part of it. But this went beautifully. So Dr. Misty Story is actually a naturopathic doctor specializing in gastrointestinal conditions with emphasis in SIBO, IBD, IBS, and celiac disease. She has celiac disease herself. She had SIBO in the past. Apparently, it's a recurrent thing. So I love when people, practice what they go through themselves. I find that great because there's much more empathy to the patient. There's more, there's everything. And actually, her passion came through in this podcast. So she currently provides online consultations regarding SIBO education for clients and doctors, and recently opened a clinic in Grand Junction, Colorado, offering naturopathic care in gastrointestinal and preventive medicine for patients. Her goal is to bring naturopathic medicine to a local community and build a more integrative and collaborative coalition between holistic and allopathic care models to best support the population. She holds naturopathic license in the states of Oregon and Idaho, and with registration for Naturopathic Doctor in Colorado. She's a board member of GastroANP, a naturopathic-focused association regarding gastrointestinal conditions and treatment, and she's a member of OANP, Oregano Association, Oregon actually. I'm just thinking about the SIBO and how to kill it, Oregon Association of Naturopathic Physicians. So Misty was trained directly by Alison Seebecker, which is probably the ultimate authority in the SIBO world. And there's something about Misty that I loved from the first contact on. She has great personality, great enthusiasm and passion, which came through, in the podcast, like I said. And we discussed many things pertaining to SIBO and SIFO, how to treat it, how to test it, I gave her my take on it. It was really a bi-directional discussion, and it was great. So I hope you guys enjoy this podcast. So welcome to an episode of the podcast, episode number 5. Today I've got with me Dr. Misty Story. She's a naturopathic doctor, and she's pretty much into SIBO as well. She was trained directly by Alison Seebecker. And I think that SIBO is like 20% of your practice now. Is that right?
It is probably more like 50 right now.
Awesome.
Yeah.
Oh, by the way, welcome to the show. And thank you so very much for being here.
Yeah, thanks for the invite.
Okay. So let's, get right into it, because I do have a lot of questions and I would like to cover them all if possible. And I don't want to take more of your time than needed. So I suggest we start with testing. So a patient comes to your office and she knows about SIBO, you suspect of SIBO. Testing, how reliable is actually SIBO testing? I assume that you do like lactylose and the glucose breeding tests.
Correct. Yeah, I do. I usually don't do glucose because glucose is usually absorbed in the first part of the small intestine. So it only really gets the upper or proximal end of your GI tract. So if SIBO is actually farther down into the small intestine, which, we have 20 something feet of small intestine. If we only get the first few feet with the glucose test, we're missing the rest of that small intestine. And also the large intestine when we're looking at methane. So I always recommend the Lactylose 3-hour test. I know a lot of places offer a 2-hour or a glucose test. I can work with those. It just doesn't give us the full amount. So if somebody comes back with a negative test on a glucose test, it could be a false negative also. So I usually recommend a 3-hour lactulose. Mm-hmm.
There's clinicians who do lactylose and glucose because they still find the glucose valid for some reason or useful. Do you consider that, or do you only do the lactylose one?
I don't do both. I know I've seen people do both. Glucose is highly accurate, actually. So that is why a lot of people want to have that. It does increase the accuracy. So if you're suspecting that they might not come up as positive on lactulose, I would understand why somebody would add that glucose. So yeah.
And how reliable do you find that test? So I'm sure that you had patients coming in, you suspected of SIBO, you run the test is negative, but they have all the symptoms, right? How reliable do you actually find this test?
That's a good question. So then we're also looking at other pieces that could be underlying that people could also have. So I don't always automatically think just SIBO. And even if somebody might have it and they have a false negative, actually kind of trust the test and look for other things like if Candida is on board or some other kind of fungal overgrowth or, parasites, anything. Like there's a lot of different things. There could be enzyme deficiencies or celiac. I look at the whole picture to see like what other pieces could and need to be ruled out. I just try to.
Yeah, because the symptoms can be very overlapping, right? I mean, SIBO and Candida and H. pylori, even they can be very overlapping. So if you have this patient coming in complaining of symptoms, you actually run the SIBO test, it was negative for some reason. What tests do you ask for?
I actually will do a whole bunch of background to see what they've had done previously. So if they've been to a gastro or their primary or anybody else, I want to see all the tests they've had run and how long ago they were run. And if I'm looking at celiac, I'm also making sure that the celiac test was run appropriately and that there's enough markers that they're looking at, because they just do like a minimum like testing sometimes just to see, and they're not actually making sure the person's eating gluten and all these different things we need to look at to make sure the test is actually reliable. So that's pieces that I look at. If I think that all that has been worked up and no H. pylori is on board, any other pieces that I actually really fit their picture, then I start looking at Candida. And so I rule out all the like easy ones. And then we look at Candida because Candida is a beast. So
Absolutely.
There's not great markers for Candida for specificity in the small intestine. But we do have a blood test. We have a urinary test. We have stool tests. Stool tests are good markers for large intestine for sure, but we kind of extrapolate, and we have over many, many years extrapolated that to the small intestine possibly too.
Yeah,
So
that was
sort
actually
of,
my next question. So how about SIFO tests? Because my impression is that SIBO tests can actually be pretty reliable, but SIFO tests are actually not that reliable. And matter of fact, we don't know the ranges for what's a Candida positive test. We don't know. Just because it's there, like Candida can be commensal, right? So I mean, we have in my view, and perhaps I'm wrong, but let me know if you think the same way. In my view, if I had a patient before me, I would say I would run a culture stool test to look for high levels of Candida, but I would also run a blood test for antibodies. The problem with the blood test is that you really have to have the antibodies for all these strains of Candida, and typically, at least in Europe, where I'm located, they look for Candida albicans in first place, and they tend to disregard the others, which is a big mistake. Actually, Candida albicans is not the most predominant in Europe, and they only test for that. And then we have the O test, which is, through the metabolites of Candida, is going to tell us something in that regard as well, with the oxalates and whatnot. So to me, Candida testing, or SIFO, fungal overgrowth, is not reliable, because we have to ask for all these tests to have a sort of accurate picture, which is still, at the end of the day, is just hints of many different tests so that we arrive at a conclusion. Did you have the same opinion?
I do, to some extent. Yeah. I don't make everybody get multiple tests just because they're super expensive, for one. And if we've ruled out most anything else that we can determine and tried diet, lifestyle, fiber, whatever, all those other pieces, all the lifestyle and dietary factors, then I will treat empirically. If I have something indicating that more, I prefer a test, and I actually prefer the oats test.
And
but
you look for the metabolites in the oat test. Okay.
I do. And that I really base on the person's symptom picture. So sometimes I will actually lean towards the stool test if I'm thinking that there's digestive marker issues or anything else underlying, or maybe parasites, because that gives me a little bit more information. Sometimes people will have both done.
Right.
And I agree with the blood test. The blood test is not specific as to where the Candida is present at all.
Right.
So we're just having some kind of reaction to it, some kind of immune reaction to it. The other two obviously are more specific to hopefully to the GI tract, but oats test can also not, it's not necessarily specific. The Ravenous that shows
Exactly.
up, they've told me when I've talked to the labs, that it's specific to small intestine breakdown. I haven't actually researched it enough yet to find out. So that is a piece that's still like on my back burner of like, I want to find out.
Right. Yeah.
So yeah, I do agree with a lot of that. Mm-hmm.
But it does also seem to me that the O test is like a bazooka, because at the end of the day, when it comes to Candida, we are only looking at it arabinose, right? I mean, you're not looking, or is there any other specific marker that you also look at?
Some of the things they look at also is the vitamin C, because we don't create vitamin C on our own. So if they're not taking in higher doses of vitamin C, but that's elevated, that's just an indicator like pointing towards possible fungal overgrowth of some sort, because fungi create vitamin C.
Yeah.
So that's one of the other indicators. And then just general like dysbiosis, but a lot of that can be the breakdown factors with like liver function and everything like that. That's when we start looking at.
Makes sense. So, and as far as the comprehensive stool analysis test, the culture test, as long as it comes out positive, you are going to treat the patient for Candida. Am I right? And there's symptoms, of course.
Right. Yeah. So if it's positive, but it's a bare positive, then I'm still kind of like, if it's highly elevated, I will usually typically treat.
Right. The thing, I mean, this is my vision. I think that most of the treatment or the treating supplements for Candida, if we go the natural route, do not harm the microbiome that much. Like caprylic acid is known not to touch the microbiome very much. SF722, things like that. So I don't think that there's much danger in treating Candida empirically. Do you feel the same?
There's the qualifier of like what we're using. So yeah, like Candida's commensal, like you were saying, there's a certain amount that should be present to keep a good balance. Obviously, there's bad actors that like to overgrow. So then we're looking at that. Caprylic acid, yes, it's not touching the microbiome directly as much, but it is a biofilm disruptor.
Yeah.
So that is part of that. So when we are disturbing the biofilms over even good growth, it's going to have impact because in our immune system and whatever else we're putting through that, that our alimentary tract can actually be impacted.
No free lunch.
No, right, exactly. But and it depends on what kind of heavy hitters some people will use with herbals. Those are not just, looking at Candida. They're not just going searching for Candida. They're actually still like a bombing of some sort. So, right. And yeah, depending on what we use, and if we use pharmaceuticals, obviously, then we're also doing, major impact too. But I do find that treating SIFO, if I think it's present, or even LIFO, if it's present, has benefited people pretty significantly.
Got it. And so the question that I have here, I mean, we talked about this, but I kind of tend to follow the script. Otherwise, I'll get off track very easily. You've had patients in the past with negative tests that you decided to treat, based on symptoms empirically, and you got good results at the end, right? This happens pretty much every month or so.
So with SIBO, I don't often treat empirically.
Right.
Candida, I will, just because I know there's not great tests. And a lot of times when I look at Candida, I am looking to make sure I ruled out everything else.
Got it. So this actually answers the first question, which is you think that SIBO testing is much more reliable than SIFO testing, right?
I do. Yeah.
Okay. I think likewise. Good to know. Okay. So as far as SIFO, we could probably say that ultimately at the end of the day, we have to run all these tests that are only going to provide hints that we do have a problem with Candida, but we cannot have a definite answer, right? And sometimes we can actually see like higher rabinos on a note. We can see high levels of Candida in a stool test, like a culture one, and we may see like positive antibodies, and Candida was not the problem. I mean, we treat the patient for Candida, and the symptoms don't get any better. Do you agree with this?
That can happen. Mm-hmm.
Right.
Yeah.
Awesome. Okay. So moving on to the SIBO test again and the lactulose. I've seen a lot of people complaining that lactulose, caused problems for them for months, even for some reason. They took it down. I've actually done quite a lot of research around lactulose. I think that after a lot of research, I arrived at this conclusion. Lactulose is not metabolized by Candida directly, which is good because people with Candida problems, they will not react to lactulose. But most of the formulas in the market, and I'm aware that in the US, it's not available as an OTC, whereas in Europe, I can just go to the drugstore and buy some lactulose. But
makes sense.
Yeah,
I will say.
yeah, absolutely. But the problem is that the formulas in the market in Europe do have lactose and glucose in them. So it's not only the lactulose. And that tends to create problems. So the only way that I found to actually have pure, quote unquote, pure lactulose was to do, manipulate it, a compounding pharmacy, go into a compounding pharmacy and get it directly. Because all of the formulas in the market do have this problem. So have you seen this in practice, like people taking a SIBO test that requires 10 milliliters of lactulose and then end up with problems?
I do have people report that where they've taken it and they just really don't want to take it again because their symptoms flared so severely.
Right.
The test that if they're not doing well with that and they really don't want to do it, I will do a glucose test instead. And then, kind of move from there. If they've already taken a test in the past and had severe symptoms, I want to see that test to see like where they actually showed on the test that, SIBO was present, whether it was SIBO or IMO, or if it was a trio smart, like if it was a hydrogen sulfide. But I'll do a glucose instead sometimes with those people.
Right. Awesome. I'm very curious to talk to you about the treatment part, and especially like comparing the SIBO with the EMO or the LIBO, but we'll get to that in a second. Why do you think it happens that people react to the lactulose so severely sometimes?
I think some people, when you think about how limited, or when the people that I see, by the time they come to me, a lot of times they have such narrow diets. They are very much starving, not only off the overgrowth of regular or the bad actors, but they're starving other pieces out too. So their microbiome is very deficient at that point, and maybe enzyme capacity at that point too, depending on how long they've been on such a narrow diet. So when they actually have this sudden dump of lactulose in their system, what they have there is like going crazy, is my impression, at least what I like to imagine in my head as a little cartoon going on, but
right. But it would be an overgrowth of something, right?
Yeah. And so the overgrowth is feeding,
right,
significantly on what they have. They've been trying to control their symptoms for so long with diet or herbs and whatever else they have access to.
Right. Yeah, I feel it's a very big problem, this diet restriction. Like people try, I myself am thiol sensitive, and thiols are present, in pretty much all vegetables and whatnot. And I found myself restricting my diet way too much back in the day. And now I realize that this is actually a big problem. I mean, I'm all for diet restriction as long as it is done in a very controlled and reduced manner, like short time frame. Otherwise, this creates more problems than those that it solves, right?
I very much agree. Yeah, I do not like having people on long-term dietary restrictions. I know there's people that have worked, when I worked with Dr. Seebecker directly, it was 2 foods, 3 foods, many years at that point. So it's not healthy in general. So it's really harmful after a while. So
yeah, I understand it's very, very, very hard to get out of that state, but at the same time, people do not realize how worse actually they are getting because they are down to a couple of foods. Or even like 10, I think that 10, 20 foods, that's still very restrictive, right? From all we know nowadays, with feeding the microbiome with different polyphenols that should come from all the different colors of the rainbow. And people sometimes end up with this, like I met someone who was basically feeding off of pumpkin and chicken breast. The problem was she couldn't do the pumpkin and the chicken breast in the same day. So it's just very sad. It's incredibly sad. And I think that this creates a lot of problems at the end of the day. Like restriction seems to lead to more restriction even, right?
And part of what I think through is there's a couple of different pieces. One is food fear. So how much our mind-body connection is obviously very much secure. It is 100% attached. So how we think is how we feel, and vice versa. So, and the vagus nerve has a huge impact going back and forth of like how that reaction is super sensitive, and the feedback is bi-directional. So it goes back and forth. The other piece is when people keep decreasing what foods they can eat, your capacity for enzymes starts to decrease because the need isn't there. Your body is not going to keep creating things it doesn't need for sustaining itself. If it's like, okay, I'm going to minimize more, I don't need to create that. That's wasting protein and energy. So, those are different pieces. So when people are on such restricted diets, I actually use some of the low FODMAPs, or like Alison Seebecker's SIBO specific food guide. I use those to tell people, okay, at least start with these pieces and start adding in a food every week to see how you do. And like start trying to actually expand using those guides, because they've already gone so far past those. And it's super important, because if you can start to rebuild the good microbiome with SIBO safe foods, this the pieces that aren't feeding SIBO as much. If you're rebuilding the good microbiome, you're going to start crowding out those bad actors and have
you have a higher chance at beating SIBO, right? At the end of the day, growing the good guys is a really good alternative to reduce the bad guys, right? And so do you agree with this statistic that is kind of known now, that 50% of patients have both SIBO and SIFO present at the same time? Does this correlate to your experience in your practice?
I actually haven't honestly thought how much, if it was actually close to that, but it would probably be pretty close. Right. I would say.
Okay.
Yeah. Luckily, a lot of the herbs and stuff that we use for SIBO also kind of cross over. So those pieces help, but I do see that people often, especially if they're relapsing significantly or they're just not getting progress with SIBO treatment, I start checking for Candida.
Right.
Or
Yeah, makes
fungal
sense.
overgrowth in general.
Yeah. So there's two interesting points that we already talked about. I mean, let me actually start by there. So you said it may actually be any fungi. It doesn't have to be Candida. What other fungi do you see as a problem and you go after?
Well, I don't know exactly what it is. Sometimes that's why I don't assume that it's always just Candida because there's so many different
But treatment
organisms.
would be the same, right?
Yeah, just because I don't have a lot of other information yet, and we don't have great testing. So
right, yeah,
just like all the testing for SIBO having progressed over this time, it would be amazing if we could actually have better testing for fungal overgrowth.
Right, right. I think that the shotgun sequencing will just bloom in the next perhaps 1 or 2 years, and that will hopefully provide us with a much better picture of what's going on microbiome wise. But I also wanted to ask you something, and I was not following the script, and so it's very easy to get off track. I meant to ask you, so when when people report problems with the lactulose and they come to you and they say, please doc, do not give me the lactulose test, I'll do anything else. And then you do the glucose test. I mean, at the end of the day, regardless of the result, you're not going to have total confidence in it, right? Because you don't trust it that much. Am I right? It's just, again, it's an indication that there may be something going on and you have to treat it, but you don't see it as reliable as the lactulose test, right?
As far as past a certain point in the small intestine. So if that glucose test is negative, then, and they still have symptoms, no, I'm not necessarily going to rely on that because the rest of the small intestine and large intestine are totally not tested at all with a glucose test. Methane, you have to test all the way through the large intestine because it's the whole GI tract where methane has impact. So without that 3-hour test, we're not covering the whole GI tract.
So if you run the lactulose test and the small intestine was quote unquote clear, and then in the long intestine, the colon, you had the spike, you know that there's a problem, like a dysbiosis problem in the large intestine. The question is, would you treat it the same way as SIBO, or do you have any specific protocols for, for something that is happening in the large intestine only?
Oh, okay. So if it depends on what's spiking in the large intestine. So if hydrogen is actually normal to spike in the large intestine, if it's methane or hydrogen sulfide, I definitely will treat. So,
but the question is, would you treat it the same way as regular SIBO?
No, because I treat hydrogen differently than methane and hydrogen sulfide.
Awesome. So we're going to get to treatment in a sec. So I'll ask you more about it. But I still have right. I still have one question pertaining to testing though, which is to SIBO and SIFO in the same patient. Which one do you treat first?
I treat Candida first.
And why is that?
So what we've seen so far with all my peer groups, that we try to keep in touch with each other to see empirically and clinically how things are progressing, if people progress or not. We found that if people have fungal overgrowth on board and they're not progressing, let's put it that way, they don't typically progress as well with SIBO treatment.
Right.
So at that point, I treat that first.
Got it. I have the very same opinion. My problem is sometimes if you treat the SIFO first, the small intestinal fungal overgrowth, and then you go after the bacteria and use herbs, you damage the microbiome. And so you potentially may have a relapse of the SIFO. Have you seen this? Does this make sense?
Claire, I think clarify your question. So just to make sure, you're saying that if you treat SIFO first,
right,
and
you
then
get rid of
afterwards,
Candida, and then afterwards you're going to treat the SIBO. You're going to do some herbals, whatever. You're going to get to treatment in a sec. And by using the herbals, you damage the microbiome. I mean, it's inevitable, right? And you may end up with a SIFO flare-up.
Right. Okay, I got you. So typically, if I treat SIFO, and then I usually actually give a break afterwards, and I want to retest to see if SIBO is still present. Because
Got
what
it.
I usually try to do is rebuild a little bit to see like gut healing and rebuilding first. Because SIFO, any kind of fungal overgrowth in general, fungi are not only chemically alter the mucosal lining and the actual GI tract lining, the cellular lining, just like, leaky gut kind of pieces, which happens with SIBO and other overgrowth. It physically alters it because it actually literally like puts its feet
Roots
into
itself.
your cells.
Exactly.
So I like to do gut healing and things like that, and then retest depending on if symptoms still come back. Because sometimes if you correct the microbiome by getting rid of that overgrowth of fungal, overgrowth, my hope is often that maybe SIBO will actually resolve too, because we still have an immune system.
And what is the percentage of cases that resolve by themselves, like an approximation in your practice that resolve SIFO when you, resolve the SIBO when you treat the SIFO?
And honestly, it's probably not severely high.
Right.
So I would say
it's
maybe
slower than desired, of course.
It's very slow. SIFO, for one, takes a long time to treat sometimes for people. And the other aspect is rebuilding all those pieces, but I still would say probably 10 to 20%, maybe.
Oh, wow.
And
so in that case, if you take a break, then this treatment may take a very long time, like the whole thing. If they have the SIBO and they have the SIFO and you take the break, we may be talking about what, a year?
Possibly 6 months to a year.
Yeah.
I mean, I know people, it is hard to be patient with that too, because people often don't feel great.
Yeah.
And especially during treatment, they don't feel great at first. But a lot of the pieces are still like keeping your body tolerating treatment too, and being able to like get through your life. So that's another piece of it too. And we're not a one pill fix all kind of treatment. I don't do that. So I just work with the body, and also trying to make sure that we're actually taking care of the body well, instead of just like bombing it.
Right. So as I'm working with people myself as a coach, I've devised this protocol. I like to go after SIFO first, and then go after the SIBO. Not because I think that SIBO resolves itself or may resolve itself. I actually never thought about it, to be honest. But what I do know is that severe cases of Candida it may just be low-hanging fruit. Sometimes you treat the SIFO and a lot of symptoms come down like really fast, and then the whole thing is much more manageable. But what I do in those cases, or what I advise people to check with their doctors, is to actually go on a maintenance dose of the SIFO while they are treating the SIBO. To prevent that relapse, that in theory makes sense, that when you damage the microbiome while treating the SIBO, then I think that, but it depends on how we see this. In my opinion, the best insurance that you have against Candida is the microbiome, right? And of course, this does not come down entirely to herbs and taking the supplement and the prebiotic and the probiotic and killing. It's just a much more holistic thing in my view. We have to look at lifestyle, stress, and all of this. Otherwise, patients will just relapse. But that being said, if we look at it merely from a herbal or a healing perspective, I tend to think that the microbiome is what keeps Candida in check, or the fungal overgrowth in general in check. And so I like to run the SIBO part with a little bit like a maintenance dose of the SIFO. That may include, a little bit of caprylic acid or SF722, which I love. Does this make sense to you?
Yeah, I've actually never done that. So that's actually something to consider, because it just kind of keeps it at bay a little bit. Because I would do similar things if I'm treating SIBO with elemental, just because like elemental diets, amino acid diets, can actually increase the risk for SIFO to occur, especially if it's like kind of low grade at that point. So I do use it with that. So I never thought about that. That's a great.
And there's two other reasons to consider that. The first one is that antifungals, especially in maintenance doses, tend to be very safe, especially like SF722. So it wouldn't hurt in principle to do that. And then a second reason would be that you have synergy from all these compounds. So in fact, some of the antifungal herbs or products like SF722, I'm not affiliated with Thorne, by the way. I just love the product. They can actually be very antibacterial as well. In my opinion, SF722 is actually very anti-H. pylori, and it works very well as a part of a holistic treatment. So that's the reason why I came down with this. And so far, people seem to agree that it's a good approach. So perhaps you want to test it out and see.
Yeah. And that's actually a really great point, because it crosses over. It is, like we were talking about earlier, it's not, some things are a little more antifungal than antimicrobial in the other aspect, or antibacterial, and some are a little bit the opposite, but they do cross over. Yeah. And that's why there's like a synergy about how they work across a certain area. It's not just targeting one thing. So,
right.
Yeah.
That is sense. The only reason why I don't like to take a break between the two, because I feel I'm gonna lose momentum if I do that.
Okay. Yeah.
Because, the transition is actually there's so much synergy that if you stop, you may lose the momentum, but it makes all the sense. I mean, I think that at the end of the day, this boils down to practical experience and a one-by-one treatment, right? And for some people, perhaps they cannot even, go through the entire treatment without stopping a while, right? So, yeah. Great. So let's talk about treatment. Okay. What's your go-to treatment plan for SIBO?
So obviously depends on what they have,
right?
What shows up and what their symptoms are. Baseline, if you're talking herbals.
Actually, the second part of the question, sorry for interrupting, would be, do you adjust the treatment of the type of SIBO the patient has? So you're answering that already.
Yeah, it very much depends on that. So hydrogen only SIBO, I tend to either use like a berberine, ADP or neem combo, not usually all of them at once. I actually do separate it out. So if somebody's going to do a 4-week treatment, which is the standard, like one round, and I base this also on like their level, and we'll go over that in a second. But I'll usually use, like, if it's a one round of 4 weeks, then it's like berberine for the first 2 weeks, ADP for the second 2 weeks, or alternate it.
Right. Do you ever overlap them?
Sometimes I'll have people do, depending on what they've experienced before with success for treatments or not, what they've used. Sometimes I will have like berberine and ADP, and then like berberine and neem.
Right.
So sometimes I'll use more than one.
And the reason why you rotate them, or you take one to put another one, is because of resistance, right?
Right. Yeah. And it is an issue when I see people coming in and they're already on combos or biocidin or berberine in general, for just maintenance for themselves, trying to self-treat, because then I'm like, well, we'll see like if it's going to actually be effective or not. Right. I think there's less resistance typically with herbals, just because there's so much variation of what they can impact and also rebuild, versus antibiotics.
Right.
But
that's actually one of the things that I like in cultural testing. You can actually get the sensitivity of some of the compounds for different bacteria, right?
Yeah, I love that aspect. That's great. That's really helpful.
That's probably one of the most useful things in the cultural testing, let's be honest.
Yeah, it is at the end. And then if it's methane, if methane is present,
right,
I usually will add allicin, because allicin obviously is the one major herb that targets that more directly. I see a ton of people come in without that on board, and they don't get a lot of progress. And I think that's a big piece of it too, because as long as methane's on board, any amount of methane, especially the higher levels, you're going to have migrating motor complex, just
constipation problems. Yeah, absolutely.
And so that we're going to have a hard time clearing SIBO anyway at that point. So I usually use allicin at that point. And if hydrogen sulfide's on board, that's a whole nother ball of wax too. So it just depends on what is in combination with that. But hydrogen sulfide, I usually will add either ADP high dose, which is emulsified oregano oil, or I actually will go to Alinea at times, or bismuth, like a variation of bismuth, usually compounded, like bismuth subnitrate or subcitrate. And if people don't have access to that or a compounding pharmacy, then you can use good old like Pepto kind of tablets, which is bismuth subsalicylate, which is unfortunately a lot more capsules or caplets, but
Yeah.
yeah.
It's a lot. It's a lot of capsules at the end of the day, but this should be for a limited period of time, and then things get better. I'm
Right.
actually very curious on the fact that you use Alenia for the hydrogen sulfide.
Mhm.
What are the doses that you typically recommend?
So with the linea,
Yeah, for Alenia
yeah.
specifically.
I'll have to double check again. I think it's a linea typically is 500 to 1,000 milligrams twice a day,
Okay.
and that's up to 30 days. And then what we
So,
are finding is that it helps with hydrogen sulfide and with methane.
oh wow. So for
Mhm.
methane, you use allicin,
Mhm.
Alenia, and perhaps a prokinetic as well for the
I
MMT.
always have a prokinetic.
Oh,
So
okay.
I don't always have
Regardless
it
of
on
the
board.
type. Got it.
Yeah, because if SIBO is present, we want to know like if it's because of deficiency in migrating motor complex. There's usually some variation of that with most cases of SIBO is what
Yeah.
we're finding anyway. So having a prokinetic on board either during treatment or by the end of treatment. And that
Right.
also depends on if people have gone through multiple rounds of treatment and just relapse. And I'm like, prokinetic needs to be on board. It's not going to hurt during treatment. The only thing is it's an extra pill.
Got it.
So yeah, I always use a prokinetic.
Okay.
It's very
It
essential.
does seem though that for methane, you use fewer compounds, right?
Methane. So with methane, I will still use rifaximin sometimes, depending
Okay.
on I guess it depends. No. So with methane, I don't just use only Alenia. I use berberine and not Alenia, sorry. Berberine and allicin
Right.
for like the first 2 weeks if we're going to do that. And then allicin and neem or allicin and ADP. I still end up having those other compounds in there.
Got it.
Even
But
if
the main
hydrogen,
one would be allicin. I guess that's the point, right?
That,
Okay.
yeah, because that targets methane. Now you got to think too that sometimes on a test we're not going to show hydrogen SIBO present, and if it's not, sometimes that's also because that is hidden
Exactly.
in the methane levels. So I am going to treat for both because most
Got it.
likely they're going to both be there.
And as far as the lineage specifically, so you said that the dosages would be 500 to 1,000 milligrams
Mhm.
up to 3 times a day for 3
Twice
weeks.
a day.
Twice a day for 3 weeks?
Twice a day for 4 weeks, up to 4 weeks.
Okay, got it. And that one you only use for hydrogen sulfide. Is that right?
I typically reserve it for hydrogen sulfide. Yeah.
Right. Okay. Do you feel that I'm very interested in this Selenia thing? Do you feel that it's very well tolerated, protects the microbiome, or at least doesn't damage the microbiome? People like it. What's your experience with it?
I haven't used it extensively just because we haven't had great testing for hydrogen sulfide up till now. And we're just
Right.
really starting to use it more often now with both.
Yeah.
So I'm still leaning towards using other things like allicin and neomycin, which is, pretty readily available, fortunately and
Right.
unfortunately. It goes both. It's got good and bad. But
Absolutely.
Alenia so far, I have seen people tolerate pretty well with limited side effects versus like metronidazole has very systemic side effects, pieces like that. So
Yeah, and between Alenia and rifaximin, would they be comparable? Like,
I still prefer rifaximin
okay,
as a type of antibiotic, antimicrobial, in that aspect because rifaximin is considered a eubiotic,
right?
and because it actually helps build lactobacillus and bifidobacter.
Yeah.
It stays local to the GI tract still also. And it's been used successively for up to 6 rounds with still having no negative side effects and supporting reduction of SIBO.
But you don't really see negative side effects from Alenia, right? I mean, it's
No,
just not well documented. That's your point, right?
Right. And just for me, clinically, I haven't used it enough to actually see the negatives.
Right.
If there were. So yeah. And I
Yeah,
can reach out to.
Yeah, because I think that Alenia is pretty safe as far as that. And it has like anti-parasitic properties as well. I just love Alenia. Like I love the guys who did it. It's not that I dislike rifaximin, but I like the natural way a lot better. And the only drugs that I really I'm inclined to accept as part of the sort of quote unquote natural treatment would be Alinea and ivermectin. So rifaximin would be kind of in the middle. So I would always, lean towards Alinea. Okay, got it. Very interesting. Thanks. Very insightful as well. So the choice, so ultimately we have this choice, right? Herbals or antibiotics. I mean, you actually said that you may mix them, right? But if we want to see this very strictly between, herbals and antibiotics, do you take that choice yourself, or do you leave it up to the patient?
I often leave it up to the patient, depending on what they have access to, what they've tried. If they've already tried one of them and didn't get success or any kind of movement, either symptomatically or with a test, then I'm going to push for the other one, obviously, because they may not be, their microbiome or the overgrowth may not be as susceptible to that previous treatment. So that's where I usually push for the option. And also depending on people's lifestyle, like can they access what is needed for the antibiotics? Because rifaximin is super expensive unless it's approved by an insurance, if it's covered. But getting the herbals is also expensive, and it's a ton of pills, and it's 4 weeks instead of 2. So it is a huge amount of, it is dependent on the patient. I very much look at the patient and their ability to access and tolerate it.
Right. I actually thought that you would be running the antibiotics for 4 weeks and the herbals for 6, but you actually do it for 2 for the antibiotics and 4 for the herbs. Am I right?
Correct. As one round. If somebody has higher levels, that's where I was talking about, or we need to go over. If somebody has higher levels on their test, and it's going to take multiple rounds to get that down, because when we look at a test, 1 round of either antibiotics at 2 weeks or 1 round of herbals at 4 typically reduces levels by about 30 parts per million on that test. So we gauge that, and you look at it and go, okay, if they're at 60 parts per million on hydrogen or a higher methane level, then I'm going to say, okay, this is going to take 2 rounds. Why don't we actually just go ahead and go for 6 weeks on herbals or 3 weeks on the antibiotics, so you can get a round and a half in and see where we are.
Right. So, and right there, so you would agree that stopping the round and, taking a break for a while and then starting again, that in that case, you would lose momentum and it's not really optimal, right? Mm-hmm. Yeah. So instead of that, going for a longer round makes sense.
Yes. Yeah.
Right. Got it. Yeah, very much agree with that as well. So okay, so pretty much at the end of the day, you leave the choice up to the patient. Your go-to treatment plan for SIBO is hydrogen, berberine, ADP, and neem. Methane would be allicin, perhaps rifaximin, and also the other compounds if need be. And then hydrogen sulfide, use the ADP, the Alinea, 500 mils to 1,000 mils, 2 times a day, 4 weeks, right?
That's
and
right.
bismuth. Right. Okay. Got it. I think
and hydrogen sulfide, it would not be all of those together. Just FYI, you pick and choose.
Okay.
Yeah. And just then also
one. Right.
Yeah. Mm-hmm.
So you could treat hydrogen sulfide with ADP only.
You can try and then see how it progresses. I mean, sometimes I'll add ADP to one of the others if needed, if it's not strong enough hitting for them. But yeah, I don't always add like bismuth and Alinea. I usually would use bismuth and ADP, or Alinea and ADP kind of pieces. Yeah.
Yeah. So you wouldn't use Alinea and bismuth together?
Not typically, no.
Got it. Okay. So the next question would be, do you test again for SIBO right after the 2 weeks for the antibiotics or the 4 weeks for the herbals to see if it is gone?
Depending on the amount that they had. So if they were close to like where that round should have, depleted it all the way, and if they're not feeling 90 or 95% better, I am going to retest.
Right.
Or that's what I push for.
Mm-hmm. Mm-hmm. But aren't you afraid that there's this 5% left at the end that may, again, over time cause a relapse, a full-blown relapse? And so either go for a little longer or test it again.
Yeah, I mean, there's the option if they're really resistant and they still have enough symptoms left. I'm just going to assume another round is going to be okay.
Okay. And by another round, you mean essentially doubling the time, right?
Correct. Unless it's like I did 6 weeks and I think only 4 weeks is needed next.
Got it.
And then the other piece of retesting is also dependent, unfortunately, on if they're doing antibiotics, do they need a retest to actually have proof that they can actually get the next round?
Oh, yeah.
So,
Got it.
yeah.
Okay, so pros and cons of formulas versus herbs, like isolated herbs. So Alison Ziebecker, I still say Ziebecker because it's German. I think in German is Ziebecker. But Ziebecker, I guess, usually talks about big doses across 6 weeks for the herbal route. What do you think about using single compounds versus formulas? So in this protocol that I came up with that I was talking about, that, you know, first I go through SIFO, I tend to leave like a maintenance dose throughout the SIBO treatment. Usually what I like to do is actually to use single compounds and rotate them all to avoid resistance. But what do you think about single compounds versus, you know, formulas in general?
So I am obviously a Alison Ziebecker fan. So, and I've worked with her for quite some time. So, in the beginning, we used to use.
I'm surprised. I was not expecting that answer.
Really?
No, I'm just kidding.
Not at all. She's a lovely, lovely woman and super intelligent. And so in the beginning, we used to use a lot of combo formulas, and that was kind of like what was going on. A lot of people did a combo formula. Started finding that, especially with people that we ended up working with that had already been through the ringer quite a bit, you know, through multiple rounds of other treatments, not making progress, going down to single herbs at our higher dose that are actually more impactful. Finding that it's actually more successful. And the other benefit to that is if people are already sensitive to some type of, to an herb, you can find out quicker, like which one they're actually super sensitive to. And if they're like, if they get a rash or some kind of other extra intestinal symptom that is like not really relatable to just die off, then we're looking at, well, maybe they're not going to actually tolerate that herb very well. So we're going to choose something different.
Right.
Yeah. So I tend to do single herbs. I prefer that versus combos.
Got it. Okay. And you also have more flexibility, right? Like if something, so I'm always thinking about the culturing test and its advantage of getting the sensitivity for each herb. And you have, like with the formulas, I feel that, you know, the patient will test very, very insensitive to one particular herb, and that formula has the herb. So there's not much point in using the formula because the herb is not going to be useful, right? And it may damage the microbiome. So I'm also a big fan of single compounds.
Yeah, that's a great addition to like why. Absolutely. Yeah, that's great.
Hi there, enjoying this podcast? Great. Subscribe to the channel for more, and also leave your like, you know, down below. Smash that like button because we're pretty much telling the YouTube's algorithm for free that this is great content and is worth, you know, sharing the word. On top of that, I would like to say that we do have a subscription model for the reports of the podcast, not only the transcription of the podcast, but also the meta-analysis of what we talk about in the podcast. I go, you know, very deep on commenting all the things that were said in the podcast, and also provide links many times to, you know, the products that we refer to, and even suggest other things for specific topics, or some other things, perhaps even giving my opinion when I'm not totally in line with the guest, depending on, you know, what the guest says. So that is in the first comment of this section. It's a pinned comment, so it will not go away. And just, check it out. Perhaps it's of your interest because you may not have the time to listen to the entire podcast all the time, or you would prefer to have this PDF that you can just read in 20 minutes and get all the information and more out of it and go on with your life. So whatever is your reason for it, just check it out. I think it will be a great addition to your knowledge and educating yourself on, you know, all the aspects of chronic illness and biohacking your body for better well-being. So I hope you're enjoying the podcast so far, and I hope that you enjoy the rest of it. We didn't talk yet about biofilm disrupting other than in the context of SIFO, Do you feel it would be beneficial to run a biofilm disruptor in a case of small intestinal bacterial overgrowth, like before treatment, during treatment?
Yep. I actually I use them quite often.
Okay.
Especially if people haven't had success or relapse quickly. And often we'll either have them start it a couple weeks at least prior to, and then determining like if they're starting to see symptoms come up or increase of symptoms, then starting the treatment. Because some people will only be able to use it for like a day or two, and they're like, oh my gosh, I'm like having so much bloating or gas. And they're like, okay, cool, it's working. Go ahead and start adding the herbs. And if people are already like, I have people come to me already started on a protocol. I'm like, okay, we'll add in a biofilm disruptor in between meals, just to like add that in, and so that everything's going to get access to those organisms a little bit easier. Yeah.
Okay, so I guess the question now would be, what are your favorite biofilm disruptors and why between meals?
Okay, that's a great question. Favorite ones, I have used Interface Plus by Claire. That was one of my originals, aside from NAC and acetylcysteine, is like one of the base ones. That I love NAC as a compound if somebody's not able to access or tolerate the other two, because it also is a precursor for glutathione. So it also adds with the detox pathways and everything. It actually helps with all of that piece, which is needed when you're treating. It's very supportive. As far as the other one is biofilm phase 2 advanced by Priority One.
Oh, I don't know
is my current preferred. And that's just, it's not new on the market. It's newer, I guess I would say, from what I, or more that I just recently learned in the last year or so. So I started using that one too. And timing between meals is just to be able to open it up so that you eat your meal, you're having your antibiotic or your herbal near that time frame, preferably beforehand. And the idea is that you're going to be feeding yourself and those little buggers. So my technical term. And so when you're actually taking your herbals a little bit prior to that, then it's actually getting into the system. They're starting to open up out of their biofilm anyway to try to access nutrients that they know is coming down the line, because you're already starting the pre-digestion phase anyway.
Right. Yeah.
And then in between, it's going to take time in between meals to open up the biofilms outside of that time frame of eating. So during fasting state is actually also a good time for doing that.
Got it.
And our immune system, people don't understand too, that our own immune system can actually be at work at that time too.
Absolutely.
So,
Absolutely.
yeah.
Okay. Got
Yeah.
it.
And if they get mixed in, and the other, sorry to interrupt. That is if they get mixed in with food, sometimes they're just absorbed instead of being able to access the mucosa layer.
Right. Yeah. Makes sense.
Yeah.
How about lactoferrin? Have you used it before as a biofilm disruptor?
I've only used it a couple times in the past, and it's because somebody was already on it. I've just not actually taken the time to use it, or I had my preferred, and so it's one that I have heard of people using. I'd be curious to see what your opinion is on it, what your experience is. So
yeah, I love it because I think that it's very natural. So the Interface Plus has the EDTA in it, I think, if I remember correctly, that there's a lot of things going on. And so the same way I'm a fan of single compounds when it comes to herbs, I'm a fan of single compounds when it comes to anything else. And so the lactoferrin is a simple compound. Like, many people react to it. Okay. But I like it because it's, if you react, you can just take it off. And because I think that busting biofilms, there's two things that I would like to say about it. The first one is that there's biofilms everywhere, and there's beneficial biofilms as well. And busting them may be a problem, right? Right. But the second thing is that they create a lot of inflammation when you bust them, right? So in my opinion, you have to go very slow. And lactoferrin is like neck. I feel like they are, single compounds that you can test and see the results very accurately. And so I like lactoferrin because of that. And it's also very natural. Like, it's in mother's milk. So it should be something that we are very familiar with. Right.
And this for a question for you, like, what do you see? Who is most often reacting to it?
in terms of biofilm disruptors in general, or lactoferrin?
Lactoferrin, yeah.
Right.
Mhm.
The lactoferrin sensitivity, like specifically, I think it's more from people who have problems with dairy, because
Mhm.
lactoferrin is often extracted from dairy, and there may be traces of dairy in, or the compound itself may behave, even though it's a dairy-free compound, it may behave like a dairy-alike product, if you will.
Mhm. Okay.
And so dairy sensitive people. And then we have to factor in the fact that lactoferrin actually boosts the immune system quite a lot. And for people who have problems with, and like, NAC also boosts the immune system, but, through a totally different pathway, like boosting glutathione and whatnot. And lactoferrin is like a directly immune system booster, if you will. And for people who have problems with that, like chronic infections, because sometimes it's not only SIBO, they have Lyme or whatever going on, right? And if you boost the immune system too fast, too much too fast, then you may have problems. So that's my take. But, and like you, I don't have a lot of clinical experience, so my realm is more like theory, and I've tested a lot of these things, but in isolation with few people who I coach, so I don't have that big clinical experience around this.
Okay.
That would be my take.
I believe I'll be looking into it more.
Yeah, sure. I mean, it's also very cheap. It's readily available. I mean, I like lactoferrin, let's put it that way.
Okay.
But I also like NAC. The only problem that I have with Interface Plus and formulas like that is that sometimes they have EDTA. That's a problem if the patient has metals, like mercury toxicity, then the EDTA messes the metals up. So again, I'm not a big fan of formulas, because at the end of the day, we may lose track of what's really going on. And I don't like that. Not a big fan of that. Got it. Okay, awesome. Nice discussion. So let's see. The next question would be, does rotating single herbs, say weekly, make sense to you to avoid resistance? Or would you say that a single herb for a next amount of time and then switch over makes sense? I think that we covered this partially, but the question now would be, do you prefer to use one herb sort of until the end of it, like for 2 weeks, and then switch to another one? Or do, on and off, the same herb on and off?
Yeah. And for the most part, like if Allison is being used, I don't have a good alternative for that herbally. So I use it the whole time. And it seems to be pretty effective throughout the whole treatment, is what I've seen for most people. But as far as the others, I usually do switch them halfway through. But at least 2 weeks is usually what I want. I don't usually do it every other week, kind of thing, because in some aspect, herbs need to have, similar to other medications and stuff, herbs need to have a certain amount of time frame to work. And obviously stopping use too quickly can possibly create that same kind of resistance pattern as we do if we see antibiotics being done. And I don't know, we don't really know that yet. So I mean, anything I've learned before was always just using the right dose and the right length of time. So for herbs as well as any other medication. So yeah.
Got it. Awesome. So let's take a step back. And the reason why I'm saying take a step back is because you would treat SIFO first if it is present. And the question would be, what's your go-to treatment for SIFO? Oh,
that's a great question. I always use caprylic acid. I love it. It's more natural and actually very effective. Has multiple different mechanisms. I'll use Thorne's compound. So if we're okay with saying brand names, I'll use that.
Yeah, absolutely. This is a free speech podcast for sure.
Yeah. And honestly, with antifungals, I actually do use combo formulas just because that's what we have the most of right now. And that I haven't played with single dose herbs for antifungals as much. But I will use Claire has a Candida complex that I get good success with. And it's still gentle enough. Same thing. It's just not like super negative side effects for a lot of people after the first couple of days usually. the first few days is like pretty intense sometimes for some people.
Yeah.
So those are my go-to pieces, along with, and we didn't get to talk about a lot of that, was the binders and pieces like that. So,
Yeah.
I mean, we can go over that in a separate piece. I
Sure.
will use pharmaceuticals at times, depending on people's success, because Candida or fungal treatment can take a long time for some people.
And that would be
and
nystatin, I presume?
I prefer nystatin because it stays local to the GI tract.
Yeah.
I have used fluconazole, and I have actually had experience with a few patients directly that they were like, okay, I started doing great on nystatin and started taking fluconazole because it was easier to access from my doctor, and nothing. Then I reverted totally backwards. And then they restarted nystatin, and I've had it both ways.
Right.
So similar to
very
SIBO.
individualized.
Right. Yeah. And so then at the same time, you're always kind of wondering like, okay, what fungus is it? Which fungus is it? Why is this one working versus the other one? Or is it just the general microbiome picture?
Yeah.
But yeah, very definitely individual. I don't see more success necessarily with one versus the other.
Got it.
But fluconazole is systemic, and it does have impact, and you need to do liver testing, baseline testing, just to make sure that their liver's not compromised.
Yeah. That's why you would prefer nystatin, because it's local.
Mm-hmm.
Got it. Okay.
Yep.
I want to know if you use S. Polarity while treating or after treating SIFO, because it's pretty controversial. Like a lot of people say, if you have Candida, you must use S. Polarity. And other people say, if you have Candida, you cannot use S. Polarity. So what's the verdict here?
I do use S. Polarity, and I don't know if the argument to not use it is just because it's a fungal-based probiotic, but it is also commensal, but in more so, I think, than Candida. Candida tends to be more the bad actor than S. Polarity. Like, we don't see as many instances so far as that we know. We don't see as many instances of S. Polarity overgrowth and negative impacts from that. So when we're killing off, I always want to like kind of promote however that ends up working in the system, like with S. Polarity, because yes, it will be impacted by the herbs you're taking, just like probiotics if you're taking an antibiotic or anything else. But I do tend to use it, and it's a helpful biller for butyrate, depending on where in the GI tract we're having issues. And it also is an immune system regulator to some extent. Same thing, you're also telling the immune system, hey, it's safe here.
Yeah.
So
I love S. Polarity. It's also very good for regulating transit time, I feel. Immune booster, when there's a lot to it. But if you decide to use S. Polarity with herbs, I'm assuming that you would leave like this window between the two of them, right?
Yeah, I usually have people take it at night before bed, and then first thing in the morning, as far away from any of that as possible.
Right. And then the herbs with lunch and dinner.
Mm-hmm.
Okay, got it. So the next question would be, do you use the S. Polarity after the treatment or during the treatment? You actually answer that by saying during the treatment, because you would space out from the herbs, right?
Correct, but I also usually extend it after. If people are tolerating it, I usually extend it after, just to help keep that rebuild and that regulation, that immune support in. And depending on what they had on board, like I said, it helps build butyrate. So for large intestine colon health, that's really supportive. So, and just, depending on what's going on or how long after, I usually have them leave it in for at least a month after treatment.
Okay, so you could run S. Polarity for about 2 months total? Okay.
Yeah.
I don't think, to be honest, because you brought it up, I was not going to talk about this, but I don't think that S. Polarity colonizes at all. That's my experience. I mean, in fact, I don't think that any probiotics colonize anymore, unless very specific ones. They just, the bugs and the metabolites, they just tend to shift the colon to a state where things balance themselves out, but the probiotics themselves do not colonize. That's my experience. Do you have the same experience?
I think the same thing. I mean, they've had more research coming out about it more and more.
Yeah.
And I think it's very transient. So if somebody's taking probiotics in any form, and the whole idea before was whether it was going to recolonize, and we don't know that. Like, and then we're starting to find out that when we do sampling, we don't see that it actually does that. And so to me, I do think that the majority of what's happening is immune regulation and metabolites being utilized. Because if they're alive, so there's the pieces too, like you get probiotics that are live and some that are not still. So if they're live, then they could be actually utilizing some food basically to create other metabolites. The other aspect of that, if they're not, and it's just genetic components of that, that's what our immune system in our gut, which is like 80% of our gut is, our 80% of our immune system's in our gut. It's sampling constantly. So when it senses those proteins of that specific probiotic, then it might be thinking at that point, okay, this is good, this is safe. Right. If it's a healthy variation of what's needed in the system. So there's those pieces, like we don't always know. And that's the thing with GI in general, is like with our microbiome, we don't always know exactly what we're doing to it, but trying our best to do with what the knowledge we have and what our reactions are for people, each person, is where we kind of try to balance that out and do the best we can. So, yeah.
Got it. And how about SIBO? So you go through the treatment and also prescribe probiotics during the treatment, after treatment. What's your take? Typically,
similarly, and again, depending on what they have, if they have methane on board, I usually do lean towards S. Polarity or L. reuteri. I don't seem to have as much
Biogaia, L. reuteri in particular?
Yeah.
Okay.
Yeah. And I know there's research backing it. I don't see as many people responding to it in a really positive way. Some people do. I actually do have people like, without that, I don't do well at all. And they just continue that, when they're done with treatment, they feel great, which is awesome. Same thing. So S. Polarity, or that is what I usually add during treatment. Again, sometimes I'll have them keep it on for afterwards, because we're still like trying to calm the immune system down, reheal the gut. So yeah, I'll use it sometimes in that aspect. Every once in a while, depending on what somebody else has already had on board, I'll use Lactoprime Plus by Claire. I like that, but as a combo formula, more Lactobacillus bifidobacter. And those are my go-tos, but I have used a variety of different things, or just looked at what other people already have, because I don't like, you've got to realize too, people are spending thousands of dollars on supplements, and so they probably already have a cupboard full. And so it just depends on how long it's been sitting in there and what it is.
Absolutely. How about for ferments, fermented foods in general?
That's a great question. So some people tolerate it really well in small amounts as they're like increasing. I do love using it. If they tolerate dairy, I like 24-hour yogurt unsweetened, because that actually, can help rebuild a little bit and provide some live culture, which is awesome. That's the piece, is kind of like what we want to. And also, just depending on the food, then you're also offering like fibers and other nutrients that come with those ferments. So
absolutely.
There's a lot of immune boost to that. So people kind of need that support, and some people don't react well to it. So it just depends on what's going on for that person. But
got it. And would you run the ferments throughout the treatment or afterwards?
Typically after.
Okay.
Go ahead.
No, I was just saying that there's this theory that if you're using antimicrobials and use the ferments, the antimicrobials are not really going to kill the live cultures in the ferments, as long as you space them out, enough. But you're kind of training the immune system and the body to have a mindset of killing, and then adding more stuff in is not really beneficial all the time. I don't know if this theory holds, to be honest, but that's why I like to question people with significant clinical experience, whether they really like to use ferments in probiotics while actively killing something. So does the question. So I remember the first time that I tried to kill a gut infection, I made a huge mistake. Back in the day, I didn't know any better, and I didn't use binders. Is this something that is a crucial part of your go-to treatment? What's your take on binders?
So I will use binders, and pretty significantly sometimes. If I know it's a sensitive patient that where they've had significant impact from treatment before. And if there's a lot of other underlying factors. If they have Lyme or if they have mold exposures, all these other pieces come at play. If they have a lot of cognitive brain fog issues like that, joint pain, then in my head, I'm thinking they're getting exposed to toxins. And when we treat SIBO, SIFO, whatever overgrowths, we are releasing toxins because anytime you open up a bacteria or a fungus, you're going to release those toxins, which is part of the impact that happens. That's why we feel cruddy when we're sick,
Yeah.
We start to get that fatigue, that malaise, and the headachy sensation. So using binders, I think, is really helpful, not only with helping that person tolerate treatment and get through treatment successfully, make their life tolerable and feel better. Binders can also help reduce methane levels directly, which is a form of the treatment at that point too. So I use immunoglobulins, or I'll use activated charcoal. I don't play a lot with the clays like the zeolite and stuff like that. I know a lot of people use it. I haven't used that. I just haven't found as much use for it. I've used that before.
How about bentonite clay?
I've used that in the past when I've worked with mold patients.
Okay.
I just don't use it as much in this aspect. I usually use activated charcoal, and just make sure that they're spacing it away from food and medications and supplements.
And the immunoglobulins would be something like mega IgG.
Mm-hmm.
Okay.
Yeah, something similar to that. Yeah, and colostrum is another version that's dairy derived. Serum derived or dairy derived immunoglobulins, because they do bind to the toxins, but they also, the same thing as what I'm thinking is that it helps regulate immune response and inflammatory response. Mm-hmm.
Mm-hmm. So we talked about leaky gut before. I guess that we should call it intestinal hyperpermeability. Otherwise, people are going to say that this is fat, right? And the question is, if somebody presents him or herself with a very case of leaky gut, even clinically, like you run zonulin and whatnot, and that person has a very high level of intestinal hyperpermeability, then the question is, would you jump right into treatment, or would you treat the leaky gut first for a while so that the treatment is better tolerated?
That's a good question. Yeah, and I think you almost answered it yourself to that aspect. If they're already in a space where they are not functional, which can happen for a lot of people, I do treat leaky gut first.
Right.
Otherwise, I will start with treatment first and then treat the gut, like to seal it back up and to help with that after the fact, because they're going to continue to have it until SIBO or SIFO is gone anyway.
Yeah.
But to give a little bit of support to see if that's actually helpful for the
we'll
first
have to address it anyways, right? So better address it first. I think that's the logic, right?
Yeah. Mm-hmm.
And what do you typically do for leaky gut?
So L-glutamine obviously is a huge go-to. Zinc carnosine is the other piece. I do still actually utilize like some ferments if they can tolerate it, and S Polarity to some extent. But those are the main few things that I start with, because I also don't like loading a lot of things into people, because I think especially because most of these patients are ultra sensitive to start with, right? And their system is already way too off balance to just throw a bunch of things and right. But as far as the L-glutamine, what would be the dose? So anywhere from 2 grams per day up to 40.
Got it. So, and do you space that across multiple doses, or it's just one shot?
Definitely. I have them use it throughout the whole day. Gives it more access to the GI tract at that point, and also being able to tolerate it, because some people that's a little too much at once.
Got it.
And so, I do have them space it, and sometimes I'll just have them slowly increase over time.
Got it. Always between meals or with meals?
Preferably between.
Okay.
So same thing. So it's getting access to the mucosal layer. It's an amino acid, so it's actually also like absorbed better when it needs to be. But otherwise it has direct access to the mucosal layer a little bit easier than having food interacting at that time.
Got it. Okay, great. Awesome. So next question. Perhaps you had patients who treated themselves in your practice. By the way, at this point, I should run a disclaimer. The disclaimer is in the description down below, but this is not medical advice. This is not intended to facilitate self-treatment. Any of this discussion is for that matter. If you have SIBO, then contact Dr. Misty Story. I mean, you do telemedicine as well, right?
Yeah. I
Okay,
do
so-
health consults for people out of my area, and then I also do patient visits for 3 states right now.
Right. So there's no excuses. Like anyone in the world can contact you. So this is really not I mean, actually, most of those things we are arriving at the conclusion that this is really, one patient is one patient. There's no one size fits all. We got to know the history. We got to run specific tests. Many people react very well to one particular compound, and then the rest of the people react very bad to that compound. So this is obviously just a general discussion for people to have like information about this. It's not intended to do anything else. But a lot of people self-treat, right? Which is
Right.
a very big problem, especially if they are using antibiotics, as we briefly touched on with the resistant part of it. But what are the biggest mistakes that you've seen people doing while self-treating?
I think part of it's like when they're treating, well, one, not knowing what they actually have. If they haven't done a test and they haven't had other workup done, I mean, we could be guessing that it's SIBO and not actually have that follow through of actually knowing like, hey, do we have celiac disease instead or something else that's actually pretty, SIBO's tough and it takes a detriment. It's detrimental to people's quality of life. But, if you're missing some other major player, then that to me is difficult. The other pieces are, either under treating and just slowly continuing to, under treat and just not getting good significant results, or just not getting it gone because you're still in that same inflammatory state for so long.
Like running antimicrobials for years, right? Some people do that.
Years and years, yeah. And the other aspect is over treating and then just kind of wiping out their gut to the point that they're actually sicker at that stage, because they don't have a good microbiome or much in existence anymore. So, and then the other piece is like, which comes with, even with any other doctor on board sometimes, is no prokinetic, which is like a huge thing that I find that people really need. And that's often why they're relapsing in the end. Not always, but very often. And treating the underlying causes. A lot of people don't understand the underlying cause and like how to make sure that that's actually treated as well as possible. And then last thing is diet. That's the big thing, is like having such a narrow diet for some people, because there's so many different diets out there online. It's very confusing, very frustrating. And like, it's really sad when I have people come in and they're only like on a couple of foods and super scared of food, super scared of mealtime, losing weight and not able to maintain anything, so yeah.
So there's a lot of potential mistakes in self-treatment. That's the main conclusion here. You mentioned so many different ones. So it's really, I also find it, I agree to all that you said, but I think that under-treating and over-treating is a big problem, and people don't know how to read tests. Sometimes they go take an online course about it, but at the end of the day, I think that one of the most crucial things is the clinical experience, and just seeing a lot of patients and starting to observe patterns that are very helpful throughout the treatment. And people don't ever get that. Like, it's impossible. They may take all the courses in the world, and at the end of the day, they will not have the clinical experience, which I think it's really important. Okay, awesome. So we didn't touch like in a very profound way in the diet. If we have the time at the end, I would like to talk about diet a little bit more, but I still have 2 or 3 questions regarding treatment. So how important is the repopulation phase? We talked about this. You said that you may use the ferments and the probiotics during treatment, as far as they are spaced out enough from the antimicrobials. But how important do you feel that this repopulation phase is in the overall SIBO treatment?
I think it's like the biggest piece aside from treatment, and is part of treatment, because people are either in that space because of dysbiosis prior to SIBO really setting in, or are going to relapse because they don't have enough support and suddenly go out and like, I'm done with treatment. I feel great. I'm going to just go eat whatever I want. And, didn't take the time to rebuild what we need to have on board. And so guess who's going to come back most likely is if there's those spaces left or whatever in our microbiome. It's most likely those bad actors, those stronger organisms are going to be the ones that are probably going to be growing again.
Right.
So making sure we take the time to, yes, I use ferments, I use probiotics or prebiotics, and start like building up. PHGG is another one, partially hydrolyzed guar gum. That's another piece that I use quite a bit. And I forgot to mention that. I use that with every methane treatment.
While the treatment?
Mm-hmm.
Okay. How about hydrogen sulfide and hydrogen? Do you use PHGG?
I don't push it as much, but I will use it still. And I use it still in the post-treatment phase because I'm working on trying to get fiber back in whatever form to start building back up. And then
as far as the PHGG, you are probably using 10 to 20 grams a day. Am I right?
I'm using 7 to 10. 14.
Okay.
Yeah.
Okay.
Yeah. Mm-hmm. Yeah. It's a skeleton. I already has a different piece of it, but I have people slowly build up. And if they can get to 7 and they're doing good, that's fine. Otherwise, if they can increase still and they're finding benefit, then I do increase.
So in the repopulation phase, probiotics, ferments, and fibers would be the go-to. And as far as fibers, you mentioned partially hydrolyzed guar gum. And is there anything else?
I actually start focusing on like more SIBO safe foods. So like I always use the little quotes things, but it's what we find as far as starting to add in
like low FODMAPs,
SIBO safe, making sure we're focusing on that. I have a whole list of like certain fibers that I have people start using and just slowly start adding those back in, making sure you have enough water. But diet is obviously, and the fiber is obviously what's going to build your microbiome the best, and also focusing on nutrient density. So colorful, good fruits and veggies that are actually still on the more SIBO safe, and then starting to expand more and more, like really literally working on that really well over 2 to 3 months at least of time. Some people need to take longer than that, but trying to really get people built out so where they actually, if they have trigger foods still for whatever other reason, even if SIBO is not on board anymore, then they might see that they're still reacting to a food or a certain amount of food, but at least they can start getting more food options out there instead of saying, nope, I got to stay here. Or I'm just going to eat 10 pizzas, so.
Yeah, absolutely not. So I actually forgot to tell you, to ask you, what's your favorite prokinetic?
My favorite is actually ginger.
Okay.
I love
like the
that.
whole ginger root chopped up or something?
No, I actually will use like 1,000 milligrams of ginger root at night. For most people, at least have that piece on board. I use it intermittently through the day, either as a tea or as root to create a tea, or even in capsules if needed, just to also stimulate migrating motor complex between meals if needed, if people are still having issues, or just for nausea, gas, bloating, all the dyspepsia kind of stuff. It's usually really helpful for that still. So these are great. I love that because it's food-based. It's safe for most people, and most people can tolerate it. I do like
I'm sorry to interrupt, but I have a very particular question regarding ginger. Do you actually use like ginger oil or ginger drops, or do you usually use the capsule form all the time?
I use the capsule form. I have never actually used ginger oil or ginger drops. And I don't know that would be negative. The only piece that I always have a little bit of hesitation with is if people are using like oils, even like with ADP, that was always like a concern. Any type of essential oil, if you're using it, that's not emulsified or
the enteric coated part of it.
Thank you. Yes, because it can actually cause caustic burns on the GI mucosa. And ginger already will cause a little bit of ginger burn for some people. So sensation anyway. The next that I would use is like Modal Pro or some kind of combo formula like that, an artichoke like that. And then if people are needing the pharmaceutical variation, I do lean towards prucalopride or Yeah, prucalopride is my main one for that. LDN, low dose naltrexone.
Right.
I like to use with people with autoimmune disease because it also is like a double benefit at that point.
Yeah.
And
And
occasionally
also
LD.
leaky gut, right?
Yeah.
Also for leaky gut.
Yeah, it has a lot of crossover. So it's
Yeah.
really beneficial if people can access it. It's compounded, so you have to have that. And then same thing with low dose erythromycin for some people. Just because it actually has impact for that, but it also has to be compounded. So,
Right.
or cut a tablet into tiny fourths. So, yeah.
Great. So, and that's used across all the types of SIBO, you said?
It can be the stronger ones like prucalopride. I usually reserve for people with methane dominance where they're having more severe constipation.
Yeah. Got it. Okay. Awesome. So let's talk a little bit about the diet. What are I guess that this is a very open question. So what are your tips regarding diet, pre-SIBO, during SIBO treatment, after SIBO? So after SIBO, you already said you try that people sort of introduce one food a week and try to rebuild their food portfolio, if you will. But how about, during the SIBO treatment and pre-SIBO? Do you have any particular observations in that regard?
Well, as far as pre-SIBO, I guess if you're saying pre-SIBO treatment or test.
Yeah, exactly. So like a patient comes to your office, you still have to do the testing, you don't know exactly what's going on. And perhaps, I don't know, but I assume that do you schedule treatment like, it's positive, let's start tomorrow? Like, do you have that kind of approach, or do you actually, give it a plan pre-SIBO and then like a few weeks after they actually start treatment?
So I usually, if I know they have SIBO, if I actually done a test and I find out they have SIBO, I will start treatment. Like I said, and if that includes working on their gut first, then we do that. Otherwise, I just get treatment going. And during treatment,
I'm sorry for interrupting, but working on a leaky gut would be the only kind of excuse that you would have not to start the SIBO treatment right away.
Yeah, as long as I've ruled out everything else.
Yes. Okay. Yeah. Absolutely.
Yeah. Okay. And biofilm, if I decide that biofilm disruptors first would be better. Yeah.
For like a month, right?
Usually 2 weeks to 4 weeks.
Right. Yeah.
Yeah.
And then that period, let's call that pre-SIBO. Do you recommend any particular diet, or would it be the same as the diet that they should follow during the SIBO treatment?
Okay, so different than what they should follow during the SIBO treatment, because I'll give people either a low FODMAP or SIBO specific food guide, some type of support directed so that they actually can find symptom management, because diet is really more symptom management than anything. So if they're having a ton of symptoms, I'm not going to try to make them suffer for the next few weeks. I'm going to help them try to figure out which foods might be triggers and how to minimize that, but still have hopefully a good variety of food in their diet.
Right.
Because my thing is always nutrient density. And then during SIBO treatment, I actually don't have them limit. I just have them limit compared to symptom management.
Right.
So if they know they don't do well with garlic or something like that, I don't say, go do garlic, I'll make you do garlic. So I'll have them eat how they would like. Because there's two, both trains of thought. Like one is, basically my thought, which is hopefully helpful, and I found it to be helpful so far, is that during treatment, you're trying to kill things off. So you're trying to actually also get them to come out of biofilm. So you're going to feed them as much as possible, because it's like during that time frame, they're not in fasting starvation mode. So they're not going to build such a strong biofilm. And other people say the opposite, that, starving them out is another aspect of that. But also at the same time, you're starving yourself to some extent. Yeah. So I like to feed the person while I'm treating. Then after treatment, I do have them try to get on a more restrictive diet. This low FODMAPs or the SIBO specific, just to also maintain their gains. Same thing with the prokinetic, making sure the prokinetic is on board at least by that time, by the end of it. And then get the retest in, with a proper prep diet prior to the test. But because then we can actually see, was that treatment successful? how much did it go down? How many parts per million? And if we're not doing a retest, then I'm going to say, okay, do you feel 90 or 95% better? I give it a couple of days afterwards, and we're just going to start talking about that. And then,
Right.
then a week or two later, do you still feel 90 or 95% better?
Right.
If you do, then great.
Yeah, absolutely. So, but it seems to me that you're actually more restrictive after treatment than during treatment. Is that right?
Correct. Mm-hmm.
Yeah. But only until you retest and you know that there's no problem. And then you open up the portfolio entirely, and, you have people adding food in like weekly, right? New foods weekly.
Right. Yeah. And it's more along the lines of like making sure they add a food for like 2 or 3 days consistently in decent amounts each day.
Yeah.
If it, reacts or not. And then if no reaction, they can kind of wait a day or two and then move on to the next food, so it's not full week, but it's kind of in that time frame. If they get a reaction, then I have them, take it back out, wait a few days till their system starts to regulate again back to a normal state, and then add another food.
And how much time do you usually have them on this restrictive diet after treatment?
After treatment and SIBO is fully resolved, it usually takes about 2 or 3 months for people to expand back out. And it just depends on the person. Some people don't. Some people just are like, I can't do that.
Right.
And at that point, we're just gauging. Like I usually keep people on a prokinetic, and, working on any other.
Because at that point, yeah, I'm sorry, but at that point, people feel better already, right? Most of the time. Right. So they feel like I can eat anything now. I mean, you're not preventing me.
Yeah. And honestly, I've had mentors and other peers do a couple of things where they just, okay, go ahead and add back in the food you miss the most, or the food that you have the most fear about.
Oh, wow. Yeah.
That's the one that you might be your biggest trigger.
Yes.
I do like support the food you miss the most.
Yeah.
I don't necessarily say, hey, go get your biggest trigger food.
Right. Yeah. But it may work. I mean, I never thought about it. It's actually very interesting. But it may work well, because I feel that at some point, like, people restrict this diet so much based off of fear. And sometimes that fear is irrational. And that is such a valid test sometimes. But if it does trigger, then yeah.
And that's the piece we always keep in mind. So that's the other piece of all this, is still working on, because lifestyle and perception is such a huge thing to alter, and it takes time. It takes practice, just like anything else. To change a habit, they probably took months or years, and they've got this new habit of food fear or whatever other triggers they might have around time of the day and what things are doing that might trigger those kind of reactions. So also getting back on board good digestive brain gut connection, rebuilding that at the same time throughout all this. And sometimes trialing and having people have that, hey, I feel great, I'm going to try this food, and nothing happens with it. They're like, that's like a huge boost for them, if that's what happens. And if it doesn't, then we're like, okay, well, maybe that's just not the food right now for you.
Right.
It may not be SIBO either. So.
Yeah. And I also assume that you cut sugar off while treating Candida, at least, or SIFO. Yeah,
when I do that, it's low processed and no sugar.
Right, but not necessarily something like keto, right?
No.
Got it. Like fruits are generally allowed in a Candida treatment.
I do, and sometimes it depends on the person, but for the most part, I still do allow fruits. Especially with whole fruit, no juice. Right. Yes. I don't do juice. Got to have fiber and all those other pieces. Exactly. There's so many other things to a compound, and to a food. So I still let people do that. And sometimes I'll just try to make them, try to be more aware of, like, if they're starting to see symptoms with higher sugary fruits, then maybe back off on that, or just a portion of that throughout their meals. Mm-hmm.
Yeah, makes sense. So, one of the last questions, any general tips and improvements use when treating SIBO and SIFO that we didn't talk about?
I think I wrote down a couple. Water.
Yeah. How much do you shoot for?
I always still say, like, the general, like, half your body weight in ounces. If you have constipation, you need to increase that. Because and a lot of times when you're saying that or increasing it, people still only get half of what you're telling them to get anyway.
Right.
So that's kind of the pieces, actually, as people listening, hopefully, like, understanding, like, really, like, trying to get at least that amount, unless you have some other heart condition or some kind of pieces like that. it's really helpful because that's the number one reason why we have fatigue and brain fog is being dehydrated. And it's the biggest thing that you can do to help your body detox properly from normal toxins, let alone what we've had going on in our system and what we've been treating. Our bucket's so full, we need help cleaning that bucket out.
Absolutely.
So,
yeah. The water part, we didn't talk about it. Anything else that comes to mind? We did talk about binders eventually. I also wrote down the sugar and the diet in general. Prokinetic, we talked about that. Biofilm disruptors. I think that we kind of gave it a good depth discussion, right?
I think that's pretty good. I think, and fiber, like, big deal on like expanding fiber, and we already talked about that.
And as far as fibers, you do them while treating the SIBO and after, right? Not only after, but also during, especially the PHEG. We talked about this because it's also I would call it a methane antagonist, right? So it's actually a killer.
Yeah. It's a reducer of methane directly. Or indirectly, I'm not sure actually how, I don't even know the mechanism for sure, but I know it reduces methane when you're treating also. And people have better success with PHGG on board while they're doing treatment than without.
So. I would like to have the answer right now from the top of my head because I would look very intelligent, but I also don't know. I think, in one way, there's definitely the body rate producers that are being fed. And so indirectly, you're reducing the methanol part. But I think it's also a killer, like a sort of reducer by itself. But I don't want to say this because then people watch and say, this guy doesn't know anything. But yeah,
well, you
I'd
can
like to know for sure. No, Misty, I know this. It's like that, but I don't.
Well, and you can always assume, like, not assume, but like figure it's a binder.
Yeah, so, exactly. Yeah, and
fibers are binders.
Day, it will reduce the methane part for sure. Yeah, and feed the body rate producers. Awesome. So, and any other fiber other than PHEG during treatment? That's actually the reason why I'm insisting in this question is because it's highly controversial. Like, a lot of people like to use loads of fibers while treating, and many people don't like to use fibers while treating and only after, because they say that it's going to feed the bad bacteria. So what's your take?
I don't push people into taking excess fibers during it. PHEG is one of the simplest ones. Yeah. I mean, I don't restrict people, but I'm not going to encourage excess on the fiber end. I just haven't done that yet. And I haven't tried it. So I don't know clinically what that would end up doing yet. I mean, it's a good thing if people are willing to try it and want to. I do have people with severe constipation that they're like, I don't want to go down on my fiber because, I'm scared. And then other people are like, I'm not doing fiber anymore. Every time I've tried it, my SIBO gets worse.
Right. And then bloat and whatever. Yeah.
Yeah. So I just temper a lot with a medium train for people.
Right. Got it. Yeah. Okay. Awesome. Last question, because I actually didn't have this in the script. I mean, I have it on my private script, but I didn't send it to you. What do you do in support of your own health?
Oh, yeah, that's a great question. I'm learning lots more as I get older. I'll say that, but I do. As far as diet, I have celiac, so that's just why I'm so passionate about it. But I gluten-free.
Actually, last time we spoke, you were in the middle of an exposure, right?
Yes. Oh, yeah. Oh my gosh.
Have you recovered from that? Yeah.
I think so. Yeah. It took a bit. Because when I get exposed pretty severely, it's not GI symptoms necessarily as much as brain fog, fatigue, and literally not being able to function very well.
Right.
So yeah, I'm much better with that at this point. Thank you. I appreciate that.
I'm glad
it's a rare thing. Yeah. So I do have,
I actually felt very guilty because I was talking to you and I was like, yeah, she's not okay. And I'm taking her time and making her focus on this. And I didn't really want to. So then after the call, I was really guilty about it.
And don't worry, it's okay. I still had to keep going.
Okay.
So I try to do the same things as I teach other people as nutrient density with my foods, making sure, and I do still keep I try to keep 4 to 5 hours between my meals because it still helps me with my migrating motor complex and feeling like, that's when you feel good, is like when you've actually eaten a meal and then a little bit later you're actually feeling hungry again when it's time for you to feel hungry, but you feel kind of clean and alert. And so those kind of pieces I notice a lot. I can't say that I don't do treats every once in a while. I love my chocolate every once in a while. I like to do dark chocolate. Yeah, I drink a ton of water and tea, but I also work out, and keep my body moving either in or outside of a gym and with my family, hiking and stuff like that. So a lot of outdoor time and a lot of movement.
Mm-hmm.
And then also meditation. I think those are big pieces, meditation and journaling.
Absolutely. Yeah. But I'm glad to see that you keep your practices congruent with someone who is a SIBO practitioner. So you do pay attention to things that may lead to SIBO, like not snacking often and whatnot, right? Yeah. Great.
Yeah, and I've had it, so that's part of the reason why.
Oh, you had it yourself?
Yeah.
Okay.
Yeah.
Awesome. Just once, you didn't relapse, treated, gone.
Oh, no, not that easy.
Okay. Well, at least you have the knowledge to go for it. Every single time it comes back, you just deal with it. Okay, great.
Yeah, I know that I don't have it anymore at this point. I've retested a couple of times and I don't have it. I do have Candida that comes back, and that's why I was like, the Candida is a beast. That's why I have a very low sugar diet. Overall. Mm-hmm.
Got it. Listen, this was such a pleasant conversation, I got to say.
Thank you.
Thank you so much for being here. I learned a lot. It was really interesting. And I'm so glad that I had you on. And probably in the future, I'll drop you an email to, bring you in once again.
Okay. That sounds lovely. It was great. I'm glad you reached out. It's been great. This has been really lovely. And it was nice to meet you too.
Yeah, nice to meet you too. So if people want to know more about you or want to do telemedicine, what's your best, I'm not going to say the best email, but the channels they can contact you?
The best way is on my website. It's drmistystory.com, which is drmistystory.com. And there's actually gives all the information about what I do and don't do. So there's all limitations for telemedicine across the state lines and, that I work in. But I do help people across the world actually at this point. And so you can schedule on there, but there's also my email, which is drstory@drmistystory.com. But that's also, all those links are in the web page. So yeah.
I'll leave the link to the web page, in the description down below.
Okay, perfect. Yeah.
Awesome.
Yeah, I'd be welcome to talk to people. I love helping people and talking to people, and yeah.
Awesome. I see your passion coming through. I like that.
Yeah.
I like that a lot. Okay. Misty, once again, thank you so very much for being on the show.
You're welcome. Thank you.
Bye-bye.
Have a good day.
Bye. Okay, so this was it with Dr. Misty Story. I loved this podcast. It's, the first one of a series of gut health podcasts. And to be honest, I think that if you're looking at taking your level to the next level, you must look at your gut. So does my interest in gut health in general, and SIBO and SIFO are components of gut health for sure, very important components. So I definitely had to cover this topic, but not only with Missy, I'll bring some other SIBO and SIFO experts for sure, and talk more about SIBO and SIFO. In the meantime, if you have questions, please post them down below. And if you want to get involved with the project, there's also the link down below, probably pinned in the comments, with URL get involved, I believe, or get minus involved, something like that. So check that out. You may suggest guests, ask specific questions, and I would be all in for, to be honest, I'm getting a lot of requests now, and I'm going through them and finding people that I would really like to have on, because I'm, like I said many times before, I'm doing this primarily for myself, to be honest, but sharing the word and helping people as I go, awesome. So I love helping people, and this is a great way to do it. But I've been getting suggestions of specific doctors that I don't particularly, see relevant as of now, maybe in the future. I do record one podcast a week, and that's enough work because I have to study the podcast, like the questions. The recording the podcast itself is usually a nightmare. I'm shooting for 2 hours, and it's a very long thing. And then also, just syncing on time zones can be pretty hard at times because I'm based in Portugal, and most of my guests are in the US, and sometimes the time zones are quite apart. But like I said, I'm primarily picking people who can talk about specific subjects that I'm mostly interested in, and as of now, I'm interested primarily in gut health. I'll probably be always interested in gut health primarily, but heavy metals is also my thing. Mold, Lyme, all these things. I'm super interested in that, like circadian rhythm, parasympathetic repair. I don't know if you noticed, but I tried to mix the words repair and tone right there. So all of this is really interesting to me, like supplements for mitochondrial energy, adrenals, thyroid hacking. That is all super interesting. But right now, I'm focused on gut health. Well, I guess it also depends on where you're listening to this podcast. Perhaps you're, listening to it like 5 years after it was recorded, and perhaps I'm not into gut health anymore. But right now, 2022, March 2022, I am very interested in gut health. That's really because I look at the gut as the basis of the human body. I would say that it's more than the base. Matter of fact, I think it's the essence of the human body, and the basis would be like the liver. So very interested in this. Very interested in methylation as well. So I'm definitely bringing methylation people over. And I'm writing a book on gut health. It will probably take years to launch, even though it's like 300 pages long already. I write everything that I learn about it because I love it. Yeah, gut health is really my cup of tea. So hope you enjoyed it. If you want to support the project, there's links below. In good health. Till the next episode. Bye.